Good afternoon and welcome to Community Conversations, Sickle Cell, the Heroes and the Facts. Please welcome the Director of Faith-Based and Community Partnerships for the American Red Cross Los Angeles region, Jennifer Johnson.
Good afternoon, everyone. As John mentioned, I am Jennifer Johnson, Director of Faith-Based and Community Programs at the Red Cross Los Angeles. I continue to hold the intention that you and your loved ones, as well as me and my loved ones, are in good health and in good spirits. I work out of the Los Angeles region and would like to thank all of our partners and friends here in the Los Angeles area, as well as all of you from all over the United States for joining us today. Welcome to Community Conversations, Sickle Cell, the Heroes and the Facts. September is Sickle Cell Awareness Month, and by the end of today's program, you will be a Sickle Cell ally. We're going to play a video for you that gives a little narrative of a woman who is a patient thriving under sickle cell and what it's like to have sickle cell under COVID. And our producer, John's going to play it for you guys.
I'm sick in the hospital. I'm terrified to be here because I don't want to catch COVID. It was like the worst thing for me to go through. This disease is really hard to have because if I am not paying attention to my body's need for rest, for water, I could go into a crisis. The body immediately goes into what's called a pain crisis or a pain episode, where those blood cells, they begin to stick and clump together inside of the body, and the parts of the body, like your major organs that really need that oxygen, they begin to hurt and throb and cry out in pain. March 31st, 2020, I had a very horrible sickle cell crisis. And if you don't know what's going on right now, the COVID-19 crisis, of course, has really hit the United States. And my primary care doctor and I were fighting to try to keep me out of the hospital. I actually was able to go to what's called an infusion clinic. I was able to get just fluids and water and be able to rest comfortably to see if my body could bounce back. Well, unfortunately, my body did not bounce back, and I began to sense it's time to go to the emergency room. I was seen immediately. The pain did not get any better. The doctors were like, "Oh no, Alexis, we got to admit you, and we definitely want to get you a bag of blood as soon as possible." But there's a problem. My doctors walked right in the room and said, "Alexis, unfortunately, we don't know when we're going to be able to get you blood." So I'm waiting in pain. I'm waiting in discomfort. And finally, the bag of blood came. The Red Cross prevailed. We got the blood down, and I was okay. My appeal to anyone who wants to give blood or who is on the fence about it, please give. You absolutely saved my life that day. I hope that you step up and become that hero. Help other sickle cell patients like me, and especially people of color. Please give blood.
I'm so happy that Alexis had the courage to share that story with us. At the end of our program, we're going to share a link that you guys, if you're interested in donating blood, how you can give from the safety of your own home. But I wanted to start this out. I heard something really cool the other day, and I learned that the Mandarin word for crisis is also the same word for opportunity. And right now, COVID-19 is a terrible global crisis, unfairly devastating, the most vulnerable amongst us. Yet, the sliver of hope that we can find as people of faith and as leaders in our community is the opportunity to connect more widely through technology. My mom is with us today, and so even though I haven't seen her in 5 months, I am able to connect with her and with all of you here. So thank you for adding a little sunshine to my day through this virtual connection. Community conversations are geared to support you as an ally in alleviating human suffering with a different topic each month. You already have tons of compassion. Our goal is to make you the most well-informed humanitarian around. My best friend, Maya Angelou, used to say, "When we know better, we do better." And sickle cell matters. About 100,000 people in the United States have sickle cell. Most are of African descent. And if we want to care about what matters to communities of color, then we have to share the burden by knowing about sickle cell. The data shows that people from all cultural backgrounds, including African American communities, lack the knowledge that we are going to share with you today. So buckle up, humanitarians. You are about to be an ally and an outlier. Now, how can we be allies? People who struggle with mental and health challenges often assume that sharing their story with friends in their community imposes a burden on others. In fact, the opposite is actually true. From a true ally's perspective, being entrusted with the care and burdens of another is a privilege. It is an opportunity to dispense generosity and a sign and symbol of trust. When both people share with each other more of their inner worlds, the more we can alleviate human suffering. The added bonus is that friendship is strengthened. And in the words of the proverb, friendship doubles our joy and divides our grief. Even though you are a generous humanitarian, your time is still precious. So we won't accept anything but the best for you guys. It is a superwoman lineup today of doctors who are out in the world supporting patients who are thriving despite their sickle cell diagnosis. We worked hard to provide different perspectives from all around the country. We even have a doctor who's sitting out the hurricane in Texas, and from different points of view in the world of sickle cell advocacy and treatment. All of our area experts will present, and then we will end our program with questions from you. So please put your questions in the chat box as the program goes on, and we'll take them and we'll ask them at the end, and we'll also be dropping information into that chat box. So keep your eyes on that. So let's get started. We are grateful to have Dr. Yvette Marie Miller as our moderator. Dr. Miller is an executive medical officer with the American Red Cross and has been with the organization for over 24 years. Lucky us. Her areas of focus include addressing the lack of diversity in the blood donor pool and identifying best practices for recruitment and retention of African American blood donors and donors from underrepresented communities. She can be found on Twitter at Dr. Yvette M. Miller. So thank you for being here, Dr. Miller, and guiding us through this important topic. Next up, we'll be hearing from Dr. Amber Yates. She is a pediatric hematologist, and she's done that for 10 years. She has a focus, her focus is on care of children with hemoglobin disorders such as sickle cell and thalassemia at Texas Children's Hospital in Houston, Texas. She is passionate about educating the public about this condition via her Twitter at SickleCellDoc. That's an easy one to remember. And then Dr. Carolyn Rowley, who is here with me in Southern California, is the founder and executive director of Cayenne Wellness Center and Children's Foundation, a nonprofit organization dedicated to health and wellness for those with sickle cell. In her role as executive director, she specializes in nutrition, health psychology, and treating patients and their families with sickle cell disease. And last, we have Dr. Wanda Witten-Sherney, and she'll be talking about her father, Dr. Charles F. Witten. Dr. Witten-Sherney is a pediatrician, advocate, CEO, and medical director for the Sickle Cell Disease Association of America in Michigan. So I'm going to hand this very important program over to the very capable hands of Dr. Miller.
Good afternoon, everyone, and thank you so much, Jennifer. I want to make sure. Oh, great. Thank you so much, Jennifer. The title of our talk today, The Heroes and the Facts, is just incredible. I was just taken by the title of the talk. So it has been encouraging to watch the increase in funding for research for identifying new methods for treatment of sickle cell disease over the last few years. But there are still glaring deficits in access to comprehensive lifespan trauma-informed care and support. Our speakers today will enlighten and inform us on their approaches to treating and supporting patients with sickle cell disease. And we will also learn about an iconic hero in the sickle cell disease community and his legacy, the creation of the Sickle Cell Disease Foundation of America. So our first speaker will actually be Dr. Amber Yates, and she will discuss the facts about sickle cell treatment.
All right. Hello, everybody. I apologize. I am at the hospital, so I apologize for any extraneous noises, pagers and such. So thanks for having me. All right. Well, I'm excited to share what role transfusions play in our patients with sickle cell disease. And as Jennifer mentioned, you can always follow me on Twitter at SickleCellDoc, where it's my passion to share all about this condition so more people know about it. Next. And so I just bring this slide because I think it's an easy representation of what these patients are dealing with. And so here on the left is a slide of what we see under the microscope of red blood cells. And red blood cells should normally be round and soft as they carry oxygen around to our body tissues. And so on the left-hand side are red blood cells that don't have a sickling disorder. And so, but on the right-hand side, you can actually see a blood smear for one of my actual patients. And so what happens is in this condition of the red blood cells, when the red blood cell gives away its oxygen to the tissues, it changes shape. Instead of having this nice round flexible shape, it becomes elongated, sharp and pointy. These long pointy banana shaped red blood cells are sickle, like the old farming equipment, which is where it gets its name. And so I think you can see two things in this this picture on the right. Number one, there aren't nearly as many red blood cells, and that's because the patient is anemic. They can't make as many red blood cells. And number two is that there are these very pointy, stick-like red blood cells all over the place, which shouldn't be there. And that, at the crux, is the problem for these patients. Next. And so the problem is that they don't flow through the blood vessels very well. And so these red blood cells without sickle in them can fold and flex and move through the blood vessels normally. But sickle red blood cells can't. They get trapped. They pile up on each other and basically cause a traffic jam, a blockage in the blood flow somewhere along the way in one of the blood vessels. And that can happen anywhere in the body, from head to toe. So even though we call sickle cell disease a blood disorder, it's really an entire body disorder because anywhere can be affected. And so all of the various complications that can happen in sickle cell disease can happen as a result of this lack of blood flow that occurs in this condition. Next. And so I think the thing that people most associate with sickle cell disease is pain. And this is a patient who's an artist who gives a representation of their pain, is what people know the most about sickle cell disease. And that's actually when blood flow to a portion of the bone is blocked by these sickle cells. And that results in part of the bone not getting oxygen. And that results in severe pain, which the patients can experience multiple times throughout their life. Next. And so one of the treatments that we may need for patients throughout their disease is transfusion, so blood transfusions. And so I kind of think of transfusions as two different ways we might use them for these patients. One is that we might need to fill their gas tank, like if they're anemia, which they all have on some level at baseline, but if that becomes more severe, is life-threatening, their symptoms are worse because they're anemic, maybe they're having headaches or dizziness or weakness because of that anemia, or if they're having a complication in addition to severe anemia, maybe we need to give them some blood to kind of fill them back up to closer to what they are normally. Or we might need to do a little bit of balancing, and maybe what we need to do is kind of tip the balance so that we give red blood cells that don't have sickle hemoglobin in them and change the balance between hemoglobin A, which doesn't have sickle hemoglobin in it, and hemoglobin S. And so that changes the balance and gives less red blood cells in circulation that don't sickle. And so these are kind of the two major buckets of reasons why we might use transfusions. but there may be some patients who almost never need a transfusions, and there might be some patients who need them quite frequently, and that is one of the variations that happen in this disease. Next. And so there's a huge host of complications that might be potentially treated with a transfusion, and some of these might be something that happens very suddenly, like a stroke, complications in the spleen called sequestration, a lung complication called acute chest syndrome, amongst others. And so there are quite a few of what we call acute complications where the patient is often ill and in the emergency room or in the hospital, where we might use a simple one-time transfusion to help them recover from that illness. But next, there are some other treatments where we might use transfusions that I think a lot of people don't know. And that is that some patients actually will require what we call chronic transfusions, where they need monthly transfusions to reduce their risk of something happening or a complication from happening. And probably the one that I, as a pediatric hematologist, experience the most is reducing the risk of stroke. So stroke is one of the most devastating complications of sickle cell disease. And we use transfusions to prevent that risk if either a patient has had a stroke previously or if they've been screened and found to be high risk for stroke. And so these children, and then even into adult years for some patients, receive blood every month. This might start as young as 2 years of age, throughout their lifetime even. And so they need blood donors every month to help them meet this need that they have. And so we need them to have this blood product available to them often, very often. And so what we know is that every time we expose them to blood, we do have some increased risk of them having issues with blood products, particularly something we call antibodies, where there's a kind of maybe a subtle mismatch between their blood cells, and that there's a possibility that the body might destroy the blood cells that we want to give them. And so there are some things that we do to prevent that from happening that I'll get to in just a minute. But one of the things that we've noticed during this time of COVID is that slowly over time, despite the fact that we continue to need these products for these patients, overall in the United States, there's been an increased need for blood products and less donors. And that actually we've had to think about how much blood we give these patients each time. And our blood bank has been like, make sure you think about it, make sure you're being proactive, and sometimes having more difficulty finding blood products for patients because it's been stretched thin. And how much a patient might receive is influenced by a lot of things: their age, their weight, what type of transfusion they might receive. So you might be as simple as what most people have seen, where you hang a bag of blood similar to IV fluids, what would you call a simple transfusion. But it can be as complicated as something we call a red cell exchange, where we actually remove the sickle red blood cells from the patient and then replace them with donated red blood cells, which requires quite a bit more blood volume than a simple transfusion. Next. So I mentioned that sometimes we worry about the patient developing antibodies where they might destroy the red blood cells that we give them. So what do we do about that? Well, this is the match game. So we match the blood as well as possible. And so we match that blood already for things we call ABO and RH, which some of you may know about, right? What is your blood type, right? Because we know if we don't, that we're going to get ourselves in a big trouble. But we've learned along the way that in sickle cell disease, if we don't do a job even better than that, that we can run into some additional problems. So we do what we call extended matching for them for these additional proteins on the red blood cells, cause C, E, and Cal. And so what we do is we match them, their blood, kind of more than the average patient. And so that's what we do to try to prevent these complications from patients who need blood products throughout their lifetime. Next slide. Where you come into this, and everyone comes into this, why it's important, is that there's a huge mismatch between who matches these patients and who is the predominant donors of our blood and products in the United States. And that is because you're more likely to match blood products to someone who looks like you because of our genetic makeups. And so my predominant Black patients of sickle cell disease are more likely to match a Black donor of blood and these CE and KEL proteins. And so we need more donors so that we can have the right blood products for my patients. And so I use this picture from a community-based organization for sickle cell disease called Sickle Cell 101 because they make great graphics. And so these patients that rely on blood transfusions is a very important part of their treatment plan. And so by just donating blood, you could be saving a life of one of these patients. And so we would urge you to think about that as a way to save a life and just another way that you can help another person somewhere in the United States. Thank you for your time.
Thank you so much, Amber. Really appreciate your presentation. And that was wonderful. So our next speaker will be Dr. Carolyn Rowley, who will discuss challenges of patients that have sickle cell disease in terms of access to care. Thank you, Carolyn. Please begin.
Okay, good afternoon, everyone. It's wonderful to be with you. And at this time, I'm just waiting for my slides to show up. I'll be speaking on the state of sickle cell disease, both global and in the US. Next, please. My name is Dr. Carolyn Rowley, Executive Director at Cayenne Wellness Center, located in California. And as Jennifer mentioned earlier, we take care of persons in California with sickle cell disease. So sickle cell disease is a genetic disease. It is a global disease. And first, we're going to look at sickle cell disease in the world. Next. So Jennifer mentioned as well earlier that September is Sickle Cell Disease Awareness Month in the US. However, around 2008, in December, the UN got together and adopted a resolution that recognized sickle cell disease as a major public health problem and one of the world's foremost genetic diseases. And as a result of having gotten together, they decided that June 19th, beginning in 2009, that's when people will celebrate World Sickle Cell Day, raising awareness. And so if you remember, June 19th is also Juneteenth. And so that is also connected to when the slaves were emancipated in Texas. So June 19th is the day for World Sickle Cell Day. Next slide. So again, it does continue to be a major global public health issue. It is a major killer of infants and children in the developing world, particularly in Africa and in India, when estimated 50 to 90% of infants born with sickle cell disease, unfortunately, will die before their 5th birthday. And I just want to talk briefly about this. So we discovered here in the US years ago how to be able to combat that. And so we know that by giving infants prophylactic penicillin, that would extend their life beyond their childhood into adulthood. And we had actually discovered that again years before. So to me, it's such a travesty that even in the 21st century, that over 50% to almost 90% of children that are going to be born with this disease are still going to die before they reach their 5th birthday. And it doesn't have to be. And we know that that has to do with access to the meds, access to care, and newborn screening, which my friend and colleague, Dr. Wanda Shoney, will be actually speaking about. So we can run a short video at this time. that you can just actually see that it is a major health issue that actually can be dealt with. Let's run the video.
Sickle cell disease. All the young people should be tested for sickle cell conditions so they will know their status. It's not a curse. Some people with sickle cell disease have lived into their 70s and even 80s. It's not a death sentence. It is important that they get good medical care so that they can lead normal lives. It is a very manageable disease.
And so that is the takeaway, that it is a very manageable disease. And as Dr. Frimpong has stated, that, and which we'll look at when we talk about in the US, persons diagnosed with sickle cell disease are living into their 50s, 60s, 70s, and 80s. Next slide, please. So by 2050, the number of people with sickle cell disease is expected to increase globally by 30%. Next slide, please. Unfortunately, approximately 1,000 children will be born, are currently born, with sickle cell disease in Africa every day. And as I stated earlier, more than half, between 50 and 90% of these children will die before their 5th birthday unless we spread the word. We spread the word that sickle cell is global. We spread the word that it's manageable. We spread the word that all it takes is for people to know their trait status, to know if they actually have sickle cell trait or not. And again, one of the things that we have here in the US is that we do have newborn screening, which will be discussed. We do realize that prophylactic penicillin does actually help in the early years. And also too, there are certain treatments that have been created, which we'll actually look at in the next slide. So next slide, please. So let's talk about sickle cell in the US. Next slide. So in terms of mortality, though people are living much longer than ever before, and that's just, I think, due to just more knowledge that we actually have. On average, though, the rate is about 45 for men and 40 for women in terms of mortality. But I do know that we are living 60s, 70s, and 80s. I say that because Kaya Wellness Center, we actually have an annual seminar in September. And this particular September, we actually have a group called Mature Adults Living with Sickle Cell Disease. And so it's going to be very exciting to listen to, see what they have to say. Many who are in their 70s and 80s. So I believe Jennifer will have there'll probably be a slide on in terms of our seminar. You're welcome to join us for those few days. I think it'll be exciting to hear for those persons who are in their 70s, how they've actually lived early and how even now in 21st century, where we are in terms of some of the different treatments. Next slide. But one thing that I find is quite abysmal, particularly living here in California, is that the rate, though, of mortality is worse in California than in the other states. I think second, trailing California is Georgia. So on average, the rate is between 25 and 30 years of age of those persons diagnosed with sickle cell disease who may die. And we're going to talk about why that is shortly. Next slide. So again, before talking about some of the barriers and why the rate is worse in California, I do want to just mention that there are currently 4 treatments for sickle cell disease. Hydroxyurea is a repurposed chemotherapeutic agent that was realized, and I want to say about 30 years ago, of the major effects that it can actually have and the benefits. And so, yes, there may be some complications, but on average, it was fast-tracked through FDA for the approval of treatment for sickle cell disease because of the benefits in terms of increasing fetal hemoglobin, decreasing the amount of hospital stays for persons. So hydroxyurea, and then it was a good 30 plus years before Indari in 2017 by Emmaus that actually came out. And then just recently in November of 2019, Novartis and Global Blood Therapeutics came out with 2 drugs specifically for sickle cell disease. Next slide. So let's talk about some of those barriers. With respect to access to care, even though, yes, there are hospitals, but there are some places in the US still where there aren't enough hospitals and far few providers who actually have knowledge of how to treat and manage sickle cell disease. So particularly for California, which is a long state from north to south, at some point when there was money in our country, we actually had far more comprehensive sickle cell comprehensive centers. Now there are very few, less than 2 handfuls. I want to say about 7. And in California, at one point we had 2. We had one in Los Angeles at USC, LAC USC, and in Oakland. Currently, right now, Oakland is the only one that is actually supported. And Dr. Johnson, who is retired, but still sees persons with sickle cell disease because he is our resident expert. So part of it is access to care where there are persons who are familiar with how to manage and treat persons with sickle cell disease. The other has to do with provider knowledge. And so there are, one is by the NHLBI that came up with a document called The Management and Treatment of Sickle Cell Disease. And then ASH, American Society of Hematology, also has guidelines with respect to how to manage and treat the disease. It's unfortunate that for those who are taking care of persons with sickle cell disease, if they actually do not have that particular knowledge, that they can do more harm than good. So one of the things that we do is we empower patients to know their disease, know how to actually take care of themselves, and we empower them to be able to stand up for what they know, what works best for them in terms of managing their pain. We also empower patients that because they live with this, they're born into pain. And if we tell them that if you have a pain that's different than what you are familiar with, please go to the ER, please see your physician and let them know this is different. And what we're finding though is because it is global, it affects persons of color from around the world with respect to in Africa, Southeast Asia, in Saudi Arabia, India, in Central America and South America, pretty much persons of color. Unfortunately, we find time and time again that persons who go into the hospital face discrimination and bias from providers and the institution itself. And so they have a hard time being able to get their pain managed because it does oftentimes require opioids, sometimes at higher doses than normal because there's tolerance that develops. And so as a result, people tend to be mismanaged. I'll say they tend to be mismanaged. I do want to just talk about a particular story that I'll never forget. And this happens, there are many stories that I'm sure that all of us have. I'll never forget Natasha. With Natasha, she was 2 years old and sickle cell disease SS. Our job is to find medical homes for our patients. She had a medical home, but for whatever reason, she didn't go to that particular hospital. Prior to her calling me, she had actually went to hospital A, where she went in. She was denied being able to be admitted. They actually did not give her any pain medication, and so she left. She then went on to hospital B. This is all in Los Angeles. And she went to hospital B, saying that she had pain. They did not admit her. They gave her something for pain one time and then said that she had to leave. She then called me when she finally made it to hospital C. And again, hospital C was not her medical home. And so I'm attempting to help her. And I said, I was kind of chastising her, saying, why didn't you go to your medical home? And she says, well, I'm here. And so I talked to the persons at the hospital. I begged them to please admit her to the hospital. I was unable to go. I was taking care of another emergency, and my colleague went and made sure that she was finally admitted. That was on a Friday. By Sunday, she called and she said they're trying to discharge me. I talked to them and said, please do not discharge her. I can be there on Monday to discuss her case. Unfortunately, they discharged her at 1 o'clock in the morning, Monday. Her oxygen was about 72. Somehow she made it home. She called and told me that she made it home. That was a Monday. I asked if a family person could take her to her medical home, the hospital that we had designated for her. She finally made it there on Wednesday. Unfortunately, it was too late, and by Friday she died. And again, my thought is that had she went to hospital A, had they believed her, had they treated her with compassionate care, had they known how to manage and treat sickle cell disease properly, that Natasha would still be here today. And that's just one story. And so I share this by just wanting to sickle cell disease matters. Next slide, please. Next slide. Our lives matter. And the last slide. And one thing that I think most people do not know is that I am an adult person with sickle cell disease. And so I want to end by saying that my life matters. Thank you.
Thank you so much, Dr. Rowley. We really appreciate that. That was a very elegant presentation. So our next speaker is Dr. Wanda Witten-Sherney, and she will tell us about her history and her legacy, and about her father, Dr. Charles Witten, and about the founding of the Sickle Cell Disease Association of America. Thank you, Wanda.
Okay, I'm hoping you can hear me, and I'm just waiting for my slides also. I'll begin by saying that it's really a pleasure to be asked to speak during this program. I've been tasked with actually speaking a little bit about two heroes in the sickle cell community and to say a word about newborn screening. So I'm going to talk about Dr. Charles Drew and Dr. Charles Witten, who have more in common than just their first names. And the reason this is so important to me is because I feel like acknowledging our ancestors is, it helps to keep them alive in our hearts. And in certain African cultures, we are actually thought of as standing on the shoulders of our ancestors. So I would like to start with talking just briefly about Dr. Charles Drew. He grew up in Washington, D.C. He was the son of a carpet layer. He actually was a very talented athlete, and he attended Amherst College on an athletic scholarship. He went to medical school at McGill University in Montreal. He graduated AOA, which is a medical honor society, and he graduated second in his class. He became an instructor at Howard University, and he did his surgery residency at Freeman's Hospital. He received a Rockefeller Fellowship to study at Columbia University. And this is what we really know him for, is that he developed a method for processing and preserving blood plasma, allowing blood to be quote unquote banked. He was the first African-American to receive a doctorate from Columbia University, and his doctoral thesis was quote unquote banked blood. He directed the blood and plasma program for the Great Britain and the United States during World War II. And then he took on the same task for the American Red Cross, but he eventually resigned from that because of the concern that blood was to be segregated. And that is to say that blood donated by Black people was only to be given to Black people. And that was a problem for him, so he left. Dr. Drew died on his way to a conference, a medical conference at Tuskegee Institute. Next slide. So I had to do a little research on Dr. Drew. I knew a fair amount about him, but I didn't have to do any research on Dr. Charles Whitten because he happens to be my father. Dr. Whitten, both of his parents were teachers. And he went to undergraduate school at the University of Pennsylvania. He went to medical school at Meharry, where he also graduated AOA. He was actually third in his class. He did his internship at Harlan Hospital, and he did his residency at Children's Hospital in Buffalo. He actually moved to Detroit because he applied for a position to be director of pediatrics at Buffalo Children's Hospital. And he was informed that they were not prepared to have a Black person in that role at that time. So he moved to Detroit to take the position of chief of pediatrics at Receiving Hospital. He did study with a very famous hematologist, Dr. Wolf Zalcer, and he looked at sickle cell disease, not only because it predominantly affected African Americans, but also because he felt like there were things that we knew about sickle cell disease that weren't being put to good use in terms of the community. So in 1971, along with a number of community-based organizations, he founded the National Association for Sickle Cell Disease. He also started the Comprehensive Sickle Cell Clinic at Children's Hospital, and that was because he felt like kids with cancer were getting comprehensive care, and children with sickle cell disease were not. And he also started the Sickle Cell Disease Association of America Michigan chapter, which is where I work now. There's another part of Dr. Whitten that a lot of people don't know about. A lot of times they know about the sickle cell contribution. And one of the most significant things about the sickle cell contribution is that he wrote the first paper that talked about the psychosocial impact of sickle cell disease, which we know it just has a huge impact on you both socially and psychologically. But another part of his life had to do with the fact that he felt that he was privileged. His father died when he was 8, but he felt that he was privileged, and there were other people who might be physicians yet for their circumstances. So he went about the business of trying to change the circumstances of young African Americans who might be able to be physicians. He started a program called the Post-Baccalaureate Program at Wayne State University. And you would apply for it if you had been rejected from medical school at Wayne State. And if you completed his program, which had a remedial aspect to it, had a lot of support, you were paid a stipend because he felt that the reason that a lot of students weren't doing well in school sometimes is because they had to work full time. And so you had to be a first generation college graduate. And during the time that he ran the program, Wayne State University graduated more Black physicians than any other medical school besides Meharry and Howard, which of course are the traditionally African American medical schools. So that was another significant contribution that he made. And I think this is a good way to segue into the next slide to talk very briefly about newborn screening. So every baby in the country is tested as sickle cell disease at birth. And there was a landmark article that was actually published on June 19th, World Sickle Cell Day, that proved that giving penicillin twice a day would dramatically decrease the chances of a child dying from a serious infection, a bacterial infection called pneumococcal sepsis. Next slide. So that is what, when we were looking for a reason to start newborn screening for sickle cell disease, people would say, well, what's going to be your intervention? And people like my dad would say, well, we're going to intervene with education. And say, no, we need something more specific than that. So penicillin actually became the intervention. So once this article was published, that really was the impetus for us being able to start newborn screening all across the country. Next slide. And in that landmark study, there were actually 215 patients, and 105 were on penicillin, and the other and 110 were on the placebo. And there were actually 3 deaths in the placebo group and 13 episodes of sepsis, and there were no deaths in the penicillin group, and only 2 episodes of infection. So literally 3 infants gave their lives so that we might learn that penicillin could make a difference. Next slide. So penicillin is a lifesaver. Next slide. And so in Michigan, when we actually serve as the coordinating center for newborn hemoglobinopathy screening. So when we get the positive results, we call the parents and we let them know about the diagnosis. And that brings up a whole other issue about the importance of knowing your trait status. Because more times than not, when we call a family and tell them their child has sickle cell disease, the mother might say, oh no, Dr. Sherney, that can't be because I have the trait, but the father doesn't have the trait. You know, and I'll say, well, how do you know that? And she'll say, because I asked him, you know, or I asked his mother, you know, and not because he was tested. So we had a CLIA certified lab until recently. We would bring the family in and test the father. And in fact, he did have sickle cell trait. But the problem is with that, when we call the family to let them know about the diagnosis, it comes on as a shock, you know, and then they have to adjust to it. And that period of adjustment, I think, is sometimes similar to the stages of death and dying, you know, that Elizabeth Kubler-Ross has described. And so, of course, the first stage is denial. So in the meantime, we're trying to get the baby on penicillin that can be life-saving, and the mother is still in denial about whether the baby has sickle cell disease or not. So that's a huge problem. So anyway, we bring them in, we do an educational session. You can see that little model of a normal cell and a sickle cell that we pass around, and what I call the Witten dice that my father developed so that we could explain the genetics. And then we have a briefcase where we give them copies of all the slides and a penicillin sticker and an ID card that tells what type of sickle cell disease the child has. Next slide. So I'm really happy to be able to talk about newborn screening because it played such an important role in increasing the lifespan of individuals living with sickle cell disease. Next slide. And so I really feel like we're doing better, right, in terms of helping people to live longer. But what we really have to address now is helping people to live better, because we need to maximize the quality of life of individuals living with sickle cell disease by any means necessary. So thank you very much for your attention. I think it might be time for some questions.
I still have, thank you, Dr. Witten-Sherney. We just have one more presentation to go. Yeah. My slides, please. Next slide, please. So today we're just going to talk quickly about the challenges and opportunities to donor recruitment and retention in the African American community to support the transfusion needs of patients with sickle cell disease. Next slide, please. So why do we need diversity in the blood supply? First, to meet the transfusion needs of the general population. Next, the donor pool should reflect the recipient population. And generally, as has already been mentioned by Dr. Yates, the best blood match for a patient requiring frequent transfusions comes from donors of the same ethnic or genetic background. And for patients that require frequent transfusions, one of the dreaded complications of multiple transfusions is the development of antibodies against the red blood cells. This is called alloimmunization. So closely matched blood can prevent alloimmunization. Next slide, please. So from my point of view, one of the major challenges for many blood collection organizations is that there is a sort of low community engagement in terms of African Americans. And so this is the way that I look at, this is the community engagement model. At the core of any relationship, our personal relationships, our community relationships, our church relationships, is that trust is at the core. And then the next thing that's important in terms of community engagement is for a particular organization to develop strategic partnerships with organizations in the African American community, as well as developing relationships with trusted individuals in the community. The organization that is trying to make entree into the community should understand and work with the community to identify what the social determinants of health are. While it is incredibly important to donate blood, the organization trying to make entree into the community has to understand that there are multiple competing priorities in the community. Donating blood is certainly an important one, but there are many more ahead of that. We also have to talk about what is, from the community's point of view, what is their responsibility in terms of health and wellness and access. Again, blood donation is absolutely important and it is key, that has already been mentioned, but we have to understand what the community receives as their responsibility. And then lastly, the responsibility that we all have, organizations that want to partner with the African American community, as well as the African community ourselves, we need to understand that we need to be addressing structural inequities and bias. Next slide, please. So we're just going to take a quick look at the census, and this is from 2019 data. It's going to be really interesting to see the census data coming up at the beginning of next year. But Caucasians represent 60.1% of the population. African Americans make up 13.4%, and Latinos make up, or Latinx make up 18.5% of the population. Next slide, please. And so that census information is important because this is what the Red Cross database looks like. And again, as Dr. Yates has already mentioned, the majority of donors, and this is across the country, are Caucasian. So as you can see, since 2017, and this is certainly not unusual, the majority of our donors, over 80% of our donors are Caucasian. And for African Americans, it's around 4 to 5%. So there is a complete deficit in terms of representation in the donor pool versus the representation of African Americans in the population. Next slide, please. So another issue I wanted to look at really quickly is the light yellow square at the top represents African Americans and the dark blue square represents Caucasians. So you can see, again, the majority of our donors are Caucasian. But in the first column, the 16 to 19, for African Americans, the majority of our donors are in the younger age group, 16 to 19, and that is 45 to 44. So compared to the Caucasian population, the population of African Americans are much younger. Therein lies another significant challenge because that we're experiencing now during COVID, because many of the high schools and colleges are not in session. And that's where a significant proportion of our donors come from, is in that high school and college age range. Next slide, please. So again, all of our presentations are intersecting. So some of the unique things about African Americans is our red blood cells have unique antigens on their surface, or proteins, as Dr. Yates mentioned, that are different from the majority of the donor population, which is Caucasian. So looking out on the left side of the screen, looking at the very first piece of information, for African Americans, 73% of African Americans have this haplotype. This is the Rh haplotype that's identified as C negative. And in Europeans, it's 32% of the population are C negative. So if you have a recipient that is C negative, has a C negative haplotype, you're more than likely going to find it in someone who is of African descent. So let's go down to the fourth bullet where it says 67%. That red blood cell phenotype is known as Duffy. And that phenotype is known as Duffy A negative, B negative. And over on the right side of the screen with Europeans, basically 0% of Caucasians or people of European descent have this phenotype. We call it rare, but it's extremely rare. So again, if you want this phenotype for a recipient, you're going to find it with in a donor that is African American. Next slide, please. And so this is just another quick example. So as was already mentioned, when we are trying to match a donor with a recipient, not only do we look at the basic antigens that I just mentioned, Dr. Yates mentioned CEK, we are also looking at other phenotypes. So in this very top example, in this antigen mix, 70% of African Americans have this specific antigen mix versus 48% of Caucasians. Not going to belabor the point. You understand how important African Americans are for the transfusion needs of sickle cell patients. Next slide, please. So how has the pandemic affected donations by African Americans? Well, we certainly know that African Americans have been disproportionately affected by COVID-19. And that's because many of those chronic conditions that predispose African Americans to acquiring the infection are high in the community: high blood pressure, diabetes, chronic lung conditions, those conditions that put us at greater risk. And for the American Red Cross, between 40 to 60% of our donations have decreased from African Americans due to COVID-19. And again, because the community has been hard hit, but also because people are reluctant to come in and donate. Again, over the summer months, it has absolutely been a struggle, because the summer months and holidays are traditional times when schools and colleges are out of session. And as I already mentioned, that we collect a significant amount of blood from that student base. And we collect about 25% of African American donors are in high schools and colleges. Next slide, please. So I hear you asking me the question, eligibility criteria, and what do I need to do to donate? So you have to be at least 17 years old. And some states, individuals that are 16 years old can donate, but for the American Red Cross, we require anyone that's 16 to have a parental consent. You have to be healthy and well. And again, that has already been mentioned, individuals with sickle cell trait are eligible to donate. And if you have any questions regarding donation, you can call 1-800-RED-CROSS. And one of the other benefits of donating is that we are testing for the antibody to COVID-19. Again, this is not the diagnostic test. This is antibodies to COVID-19 to identify if an individual has been exposed to COVID-19. Next slide, please. So these are some of the safety measures that Red Cross has in place. Blood donation is an essential service. So again, it is important for us to remember that blood is a perishable resource, and that we constantly need blood donors, and we constantly need to refresh the blood supply. Everyone that enters the Red Cross donation site, donors, as well as our staff, are required to wear a mask. And if a mask is not worn, it is given to the individual. We also take temperature, and we ask specific questions about exposure to COVID-19 before a donor can enter into the collection site. And we also employ deep cleaning, as well as we adhere to the exposure prevention recommendations by the CDC. Next slide, please. So lastly, I also hear you asking me, how can I help patients with sickle cell disease? So please make an appointment, and you can do that by calling redcrossblood.org. Going to redcrossblood.org, that's our website, calling 1-800-RED-CROSS, or we also have an app that you can download. And also, as important as making an appointment to donate is please stepping up and hosting a blood drive. This link, these slides will be available. This link, you can go to the redcrossblood.org website and actually enter information and find and identify that you want to host a blood drive. But you can also call 1-800-RED-CROSS and get information about hosting a blood drive. Next slide, please. So again, thank you so much for your attention. And any place I am is Saints country because I'm a Saints fan. So this is the last slide. So I will turn the, and thank you again for your attention. I will turn the program back over to Jennifer.
All right. And at the very end of the show, or the program, we're also going to provide a link, and it's what's called the Sleeves Up campaign. So it's anybody in the country can click on this link and make an appointment that works for them, closest to their home, closest to their work, at a time that works for them. And you can also post that link. It's going to be dropped into the chat right now. You can share that link with on your social media accounts, and we'd really love that. That would be a way you could be a sickle cell warrior with us. There were a couple of questions that came on, so thank you, Dr. Yates, because one of them is for you. There was a question about malaria and sickle cell. Did sickle cell happen in a response? Because we see that more people of color, also Latinos, East Indians that have sickle cell, is there anything to do with malaria?
So that's actually a great question. And so they are connected. So the reason why we find sickle cell disease in areas where there is malaria is that having the trait, so not the disease, but being a carrier for this condition, is somewhat protective against malaria. So people in these areas of endemic malaria in sub-Saharan Africa and India and things like that, if they have the trait, are less likely, not impossible, less likely to have the malaria infection. And so it's kind of why evolutionary it exists. The problem is when you have two copies of the sickle hemoglobin and you get the disease. And so that's at its heart, but they are very much connected as far as where they come from. And there are several hemoglobin disorders which are very connected to malaria and their regions of where their origin come from.
Shows how dangerous mosquitoes have been in our history. Thank you for that. That was okay. And I have another question that is for Dr. Rowley. Where can people find out their trait status, and how hard is that test?
So in terms of newborn screening is now in every state. And so for the past, I want to say between 20 to 30 years, it is mandatory so that when you have a baby in the United States, your baby is screened. And one of the screening is for sickle cell. If you are older, say, than 20, well, let me step back. So like Dr. Sherney had stated, parents are told that their babies have the trait or the disease. But now the parents have to try to remember, if their baby has the trait, try to remember to share that with that child, say during the teen years, and then again, maybe when they're an adult. So oftentimes people forget. And so even though they may be 20 years old, they may not have been told, or their parents may have forgotten to share that with them. But to answer the question, you can go to your physician and ask for a hemoglobin electrophoresis. This is what they do to test to see if you have the trait and or the disease.
And does newborn screening test for both the disease and for the trait?
Well, it tests to see if you have sickle cell disease, and as a result, it will also share whether or not you have the trait. Mm-hmm.
Okay.
But if I could just add to that, the follow-up for sickle cell disease is really good. But the follow-up, if a baby is diagnosed with sickle cell trait, is not so good. So you may not have been notified. You're definitely going to be notified if your child has sickle cell disease at birth, but not necessarily sickle cell trait. So just because you haven't heard, then that doesn't mean you don't have it, and you should still get tested.
Thank you. That's a really good distinction. I appreciate that. And then this one's for Dr. Rowley. One of the questions, is there any other way other than genetics that someone can get sickle cell?
No.
Okay. And is there, and this is for Dr. Witten-Sherney, is there an alternative if a baby has sickle cell and is allergic to penicillin? How do they treat that child?
We give them another antibiotic called erythromycin, but true penicillin allergy is very uncommon. Sometimes I have parents, the baby gets a little red rash that is really a drug reaction and not an allergic reaction, but then they're really afraid to give the penicillin, so I end up having to put them on erythromycin because they're concerned. And then another thing that comes up is the mother says, well, I'm allergic to penicillin. Does that mean that my baby will be? And it does kind of run in families, but not exactly the same way with direct gene connection the way sickle cell does. So those are the issues.
And I have a question that's for Dr. Rowley. Why are the numbers in Africa going up? When you said that the numbers are increasing, is that because population is increasing? Is that because testing is increasing? Or is there something else at work here?
I would say a little bit of both. So one thing is, let's talk about the reason for the mortality first, is that newborn screening, as we know in the US, newborn screening saves lives because now we know that persons have sickle cell disease. And so we can get right on that. In countries where they do not have newborn screening, they just don't know. And so that if we were to increase, if we had newborn screening globally, I think it would actually save lives. The second thing though is, like we know about prophylactic penicillin, but the problem globally is that now they have to have access to the prophylactic penicillin once they find out that the babies have sickle cell disease. So it's a little bit of both. It's getting them screened, but also having access to the treatments.
And if I could also just add to Dr. Rowley's comments, one of the problems is the driving force of malaria. So malaria is still endemic. I mean, in Nigeria, where you have the most people with sickle cell disease on the face of the earth, the incidence of sickle cell trait is 25%. 1 out of 4 people have sickle cell trait, whereas in the United States, where we don't have malaria, and the reason you see sickle cell disease in the United States is because of the slave trade. So we brought our sickle cell genes over here with us, but we don't have a driving force for it, for the gene frequency to increase the way we do in countries in Africa.
Thank you. That's a really, really good point. And those were all of my questions.
I do have a point. Yeah, I have a point of clarification. So the theory or the myth, I guess, that Dr. Drew left the Red Cross because it was in opposition to the segregation of blood is not accurate. And the research has been done on this. He actually left, he was absolutely in opposition to segregating blood, but he left the organization before that came a unified policy. So I do want to clarify that piece of information, and that has been clarified by Dr. Drew's daughters as well.
Oh,
and I've heard them share that as well.
That clarification. I wish I'd had the opportunity to talk to Dr. Drew's daughter, and then I would have given accurate information. Thank you so much.
It's just an opportunity for us to get it right, because I know in all of the research I've done for Dr. Charles R. Drew, how often that has come up. And then when Miss Sylvia Lacey or Miss Sylvia Ivy Drew mentioned it, I was like, oh, that's not what it says on the internet. So,
and I think there was some kind of myth too that he bled to death on the.
Oh, right.
That's exactly right. That's part B.
I didn't
You're right.
That one.
That's right. There is the myth that he died because he didn't get a transfusion, but he actually died from his injuries, which were catastrophic from the car wreck. So it wasn't, he died because he didn't get a transfusion. his injuries were fatal.
Well, I think we can have a whole conversation on Dr. Charles Ardrey. And
We can, and we will one day.
We're producing a bag from the Red Cross that's our line of heroes totes, and he's going to be on our first bag, and they're really cool. We had a real designer do it, and because we want people to be excited to carry it around. So I will mail one to all of our panelists.
And I saw a sneak preview of it, and it's beautiful. And so you will all be so glad to get it and cherish it. And thank you, everybody, for your presentation today and for participating in this webinar. It's been joy. Thank you.
Thank you.
And I'll wrap it up. So thank you, Dr. Miller, Dr. Yates, Dr. Rowley, and Dr. Witten-Sherney, not just for your time today, but in all the time that it took to coordinate this. So thank you for every minute of it. We were lucky to have your talent and your guidance today. We are also super thankful to Gerald Thomas and our friends who are joining us from the Red Cross in the Southeast and Caribbean Division. And we're grateful to each and every one of you here, including the community response system of South Los Angeles. It was really helpful in spreading the word about this event. I appreciate all of your help in showing up and getting other people to show up. Your presence today and always is a gift. And thank you to John and Kendall, who I think did the heavy lifting for this program's logistics. And then our next one coming up is our next community conversation is on Wednesday, September 9th at 1 p.m. Pacific, because we're out here on the West Coast. And it's an opportunity to turn your compassion into action by celebrating Disability Pride with the Disability Community Resource Center. So join us as we learn to fully embrace the concept of disability pride and mental health 101. And did you have a statement, Dr. Rowley?
I do.
Yes.
So if I can give a plug, I mentioned it briefly during my talk that Cayenne Wellness Center is celebrating our 12th annual Sickle Cell Disease Educational Seminar. It is even though it is statewide, it's now regional. We usually bring in about 300 physicians and patients, but it is virtual this year. It is for 3 days, September 17th, 18th, and 19th. Our theme is a global approach to sickle cell disease. We have panelists coming from all over the world who will be on, from Bahrain, Kenya, France, Brazil, Canada. So we're really excited about that. We have Professor Dame Elizabeth from the UK, who's our keynote speaker, Dr. Amar Zaidi, and the list goes on. So I'm just inviting our guests who are here now to be able to just go on to CayenneWellness.org. Registration literally takes less than 60 seconds. Thank you.
And for physicians, there are CMEs going to be offered for this 3-day webinar online event.
Thank you, Dr. Miller.
Absolutely, that's precious. Thank you.
And after this session, everybody who attended or registered will get what we call as our wrap-up email. It'll list all the resources that we mentioned, and in that will be the flyer and the link for you to register if anybody's interested, which I hope you guys are, in the seminar that Dr. Rowley was talking about. As well as we have graphics that you guys can share on your social media accounts to help us spread the word about sickle cell awareness. And as you know, there is no widely used cure for sickle cell disease. However, the Red Cross supports one of the most critical sickle cell treatments of all, which we mentioned, which is blood transfusions. And so for many patients, a close blood type match is essential and is found in donors of the same race or similar ethnicity. So basically, Black blood saves Black lives. Regardless of your racial background, though, you can be a sickle cell warrior. So please use the link that's in our chat box right now to be a sickle cell warrior blood donor in the month of September. And as Dr. Miller mentioned, you will also get a complimentary COVID-19 antibody test. And the results will be, I think they'll send it to you in the app, and it's pretty quick. It's safe, and you can do it from the location that's closest to your home on your own time. So in closing, we see sharing in someone else's struggle as an opportunity to dispense our generosity. And that's why you guys are here, because you're all humanitarians with loads and loads of generosity. So thank you again to our panelists. Thank you for everyone who gave this time to us and gave us your attention. It really is precious, and may peace be with you. Have a good afternoon, everybody. Thanks so much.
Thank
Thank
you.
you so much, everybody.
Guys.
Thanks, everybody.